Hey everyone, our STFM project is titled Multidisciplinary Medication Reconciliation, a collaboration between residents and pharmacy team in a family medicine outpatient center. The project was led by two residents at MacNeal Hospital. I'm Vivian Harvey.
And I'm Madeline Knott.
We partnered with our pharmacy colleagues, Dr. Daniel Majurzik and Dr. Ashley Stefanski, as well as a number of pharmacy students. In the primary care setting, medication discrepancies have been shown to increase risk of adverse drug events and hospitalizations. For example, according to the World Health Organization, 6 to 7% of all hospital admissions are medication related, with 2/3 of those errors considered avoidable. One way we can decrease medication discrepancies is through medication reconciliation in the clinic. Medication reconciliation, although a very important element of a clinic visit, often poses a challenge. Taking a look at QR code 1, you can see several factors that contribute to why these reconciliations are not performed. The provider often lacks time at the visit or may assume the EMR is already correct. Patients often don't know their medications or may see prescribers outside of the medical system whose medications do not reconcile into Epic. Finally, at our institution in particular, we switched from one EMR to a different EMR a year before the project began, which likely led to some of the medication confusion.
Our study implemented a pharmacy team, including clinical pharmacists and pharmacy students, to perform medication reconciliations at the MacNeal Family Medicine Center, also known as FMC. The purpose of our study was to evaluate what risk factors are associated with an increase in medication discrepancies. Because resources are limited in the outpatient setting, pharmacists are not able to perform medication reconciliations for all patients, and we wanted to identify which patients would benefit the most. QR code 2 shows previous work in the area of interdisciplinary medication reconciliation. Student pharmacists in one outpatient family medicine center identified 2.6 discrepancies per patient medication reconciliation. A study which implemented pharmacy students in a hematology oncology clinic found that 88% of patients had at least one medication discrepancy. Finally, another study showed hospitalized patients who had a pharmacist perform discharge medication reconciliations had a reduction in readmission rates from 20% to 6.5%. if their medication was done by the pharmacist. Moving on to methods, our pharmacy team performed medication reconciliations for patients meeting inclusion and exclusion criteria at the FMC in a cross-sectional study, as seen in QR code 3. All patients were 18 years of age or older with 3 or more chronic medications who had visited FMC at least once in the last year before the start of the project. The patient was called by the pharmacy student a few days before their appointment and given 2 chances to pick up the phone. Any patient who refused or did not pick up was excluded from the study, and no patient was repeated twice. The student spoke with the patient to confirm their medications and gather demographic information and comorbidities for each patient. The student then called the pharmacy and noted the discrepancies in a note sent back to the patient's primary care doctor to be reviewed for accuracy. When reviewing the medications, we wanted the differences noted to reflect only meaningful discrepancies. So we only included chronic medications and meaningful PRN medications, such as Xanax and Norco, but excluded Tylenol and ibuprofen if rarely used. We decided to include all vitamins. Any medications prescribed as a short course were excluded, and medication equipment was also excluded.
A question we asked ourselves during this project was, which is the correct medication list? Is it what the patient thinks they're taking? Is it what's in the EMR? Or what the physician thinks the patient should be taking? In the end, it is a philosophical question with no clear answer. Thus, we decided that the medication list in Epic would be the standard of comparison. We defined the term discrepancy to mean an inconsistency between the Epic list and patient adherence, or an inconsistency between the Epic list and the pharmacy record. In QR code 4, you can see the risk factors we kept track of for each patient. These included demographic factors such as age, gender, language, hospitalization history, and total number of medications. We also kept track of comorbidities such as anxiety or depression, diabetes, heart disease, asthma or COPD, hypertension, and kidney disease. In discussing our results, we completed a total of 89 medication reconciliations. We identified the mean number of discrepancies to be 2.21 per patient, and the mean number of comorbidities to be 1.72 per patient. We also calculated the mean number of medications each patient was on prior to medication reconciliation, which was 6.74, and after medication, the number, which was 6.29. All of the risk factors and demographics were insignificant, except the following data in QR code 5. Looking at the first figure, you can see we found a statistically significant correlation between the pre-MedRec number and the number of discrepancies, with a Pearson correlation coefficient of 0.403 and a significance of 0.000. This makes sense and is expected. Proportionally, if a patient takes more medications, then there are more opportunities for discrepancy. Additionally, patients who are on a higher number of medications may have difficulty taking them correctly. Finally, polypharmacy makes things harder to reconcile for physician and pharmacy as well.
Moving on to the next image, we used chi-square and Fisher exact test methods to analyze our categorical data. We worked with a statistician to determine the expected proportion, seen in gray, of patients in each of the three categories: 0, 1 to 3, and 4+ discrepancies, predicting how these numbers would fall if there was no relationship. Then we plotted the data and compared the actual values to the expected values. If you look at the actual values seen in the green compared with the gray bars, you can see patients with anxiety and depression skew towards a higher number of discrepancies compared to patients without anxiety and depression in the first graph, which demonstrates significant statistical significance with a chi-square significance of 0.028. Some possible reasons for this include mood symptoms associated with anxiety and depression can make it difficult to consistently and correctly take any medications. Our patients often see a psychiatrist that is not in our electronic medical record system, and sometimes we do not have records of those medications.
Looking at the next slide with asthma and COPD, and again focusing on the orange bars with actual data compared to the expected gray bars, patients with asthma or COPD also skew towards a higher number of discrepancies compared to patients without asthma and COPD, which demonstrates statistical significance. The p-value using this time Fisher exact test was 0.019. The reasons for this could be many, the main one being that inhalers are often complicated, expensive, and incorrectly used. Going forward, this valuable data could be used to target high-risk patient groups in our clinic who could benefit most from an interdisciplinary MedRec. Thank you.